All right. Thank you so much, Deval and Danny, for the invitation and to be here among all these amazing colleagues and friends and current fellows and former fellows. So I'm the imager who gets to keep you awake for the last few moments. And after all these amazing devices and groundbreaking procedures, we're going to talk about echo. But from the imaging perspective and multimodality perspective. So paravalvular leaks, we all see them. They're common, but sometimes hard to diagnose. Risk factors, think about calcium, think about abnormal tissue to begin with. And definitely bulky calcification is a problem for TAVR in the sense of PVL. When we look at the guidelines, what the guidelines tell us, they don't provide that much guidance. They really tell us it's the most severe cases that you have to fix in patients who have heart failure or severe hemolysis and are non-surgical candidates. But are these really the patients we need to reach out to, or should we diagnose this and treat it sooner? The one slide about data that I'll show, I promise, but this is for the TAVR data on the left. It's a meta-analysis, and on the right side, a surgical data, a retrospective data from multiple sites. And as it turns out, mild PVL is not as benign as we used to think. Conventional teaching is that moderate or severe PVL is what we need to treat. So we have to be very careful, and we have to know how to diagnose it, how to recognize it early on. And that's what I'll talk about today. So the challenges with imaging PVL is that these are not like native regurgitation. These are many times multiple jets, non-circular, crescent-shaped, eccentric, oblique. They have unusual locations. There's the effect of acoustic shadowing from the devices or valves that we're imaging. And guidance can be extremely challenging as well. So based on what I just showed you, I probably need to modify this slide because mild PVL should not necessarily be a thumbs up. But for severe PVL, what do we look for in TAVR? We look for a vena contracta width, if you can find it, because it's not so easy to find, vena contracta area of 0.3, circumferential extent of more than 30%, large flow convergence, a short pressure half time, and diastolic flow reversal in the descending aorta. If you're not sure, and many times we're not, you have to do additional imaging, do a TE, do multimodality imaging, CT, MRI. For mitral valves, we look for abnormal device morphology, rocking motion, dehiscence. We look at the vena contracta width, vena contracta area with 3D MPR, flow convergence, large jet, and pulmonary vein systolic flow reversal. So this is pretty standard evaluation. Issues here are when we do our traditional parasternal short axis view, we might not see the leak. This is a TAVR valve, and as shown here, any jets that are posterior to the valve between 4 and 8 o'clock, you might not see them. So you really have to interrogate from the apical windows, and this could actually be pretty significant and be completely unapparent if you're not looking carefully. We need to integrate multiple Doppler parameters, as I showed you earlier, and just be very methodical with these patients. And for these TAVR patients, we always want to see the descending aorta before the procedure because a lot of these elderly patients have a little bit of reversal to begin with, so to make sure we can compare pre and post. We don't quantitate very often, but we should think about this, and we can use the Doppler method, comparing the volumetric stroke volume from the LV outflow with the RV outflow to determine what the regurgitant volume is. And for mitral, we're in this case, because these are not native valves, we can't use the mitral annulus as a reference point, but we use the volumetric method from the LV stroke volume, and we compare that with the LVOT stroke volume to get a quantitative regurgitant volume. I was talking about vena contracta area, and what that is we use a very, very small, high-quality color 3D data set, and we try to find that jet that is eccentric, oblique, and trace that area at the narrowest point. And that can be very, very helpful in paravalvular leaks. Localizing the defect, this is the so-called glass view transparency, which some people think it's a gimmick, but it actually can help you a lot in these leaks because it shows you where the jet is coming from and where it's going. For procedural planning, we have to size it correctly using 3D MPR as well. And this is where multimodality imaging shines. So having MRI to quantitate leaks when they're unclear, you can get a more precise regurgitant volume, regurgitant fraction. Having CT to localize the leaks, size the regurgitant orifice, and do pre-procedural planning. And I'm showing some slides here of what's called fusion imaging, where you can overlap these data sets with little markers pointing at where the leak is on the fluoroscopy screen. Because it's going to be very challenging for the interventionalist, the proceduralist, to pass a wire through that leak if you can provide excellent guidance. So I'll just show a couple quick cases. Access for a mitral leak is tricky because you're gonna have to plan ahead depending on where this leak is. Lateral and anterior leaks might be easier to access than posterior and medial leaks. Typically, they'll go posterior and inferior, but they may need to modify this a little bit depending on the location of the leak, or even go retrograde. And this is a case where it was a very large defect and it was a non-surgical candidate. And we could start by deploying one device, VSD occluder, but as you can see, that PVL was very elongated and it was extremely challenging to cross that residual defect that was very, very medial, despite multiple attempts. But the result was an improvement in the regurgitation. And this is something that also was a little scary. The defect was crossed. This is a mechanical mitral valve. Occluder device gets deployed, and look at what happens there. So it's interacting with one of the leaflets. Luckily, this was able to be resolved, and the result was excellent. So these are tricky, very tricky procedures, and I'm sure Dr. Silva and Dr. Conneru would agree. These are not easy procedures from the technical aspect for the operator as well as for the. This is an aortic post-TAVR PVL, and again, live 3D NPR guidance. You need more than fluoroscopy to guide these procedures to make sure the wire goes precisely where the leak is. Look at the size of that leak. It's very, very discrete. And then place VSD occluder in this case with significant improvement in the regurgitation. You can see the short axis view and the transgastric view. Just like I said, for the transthoracic echo, we have that shadowing in a TE. Exactly the same thing happens, except it's the other side of the valve. You have to go transgastric to make sure you're not missing any leaks. And I kept it short as promised. So last talk of the session, I'll be happy to take any questions. Thank you.